Welcome to Didactic Residency Edition. Today is Saturday, November 11th, 2023. I am Dr. O'Leary, a fourth-year psychiatry resident in the National Capital Region. That means that I am in my last year of training before I take my boards to be a grown-up psychiatrist. I say this to warn the listener that, although I think I'm smart enough to make this podcast, I am just one person. My opinion is only my own opinion, and I don't pretend to speak for anyone else, whether it be the federal government, the Department of Defense, or the American Philatelic Society. I also designed this for an audience of other psychiatry residents or attendings or med students, but I hope anyone can learn something from it. Today, I'm continuing an intermittent series called In a Word. The difference between prior episodes and this one is that today I actually have two words. I chose these words because, I don't really know the difference between them, and even after reading and trying to understand the difference, I'm not sure that there is a very clear difference. And I think it's important as a psychiatrist that I humble myself enough to admit that at times I don't really know what I'm saying, and I don't think my entire field has a good grasp on what we are saying. Sometimes. The two words I chose today are impulsive and compulsive. If you think about the shared root of these words, that pull, P-U-L, or like pel, P-E-L, another derivative, it's from the Latin, you may notice that there are like many words that contain it. Other than impulsive and compulsive, there are words like propulsive, repulsive, expulsive. In astronomy, there's a pulsar. It's a type of star. When something moves back and forth, it is said to pulsate, and this is most often used to describe things like light or like volume, like the volume of an artery when you're feeling it while trying to get the pulse, or lungs might be said to pulsate by the air going in and out. Using the derivative pel, P-E-L, which is just another form of pull, there is impel, repel, dispel, compel, expel. P-U-L or P-E-L represents some kind of forced or directed action. Something moves or changes. When applied to psychiatry, this is basically referring to a behavior that has some kind of intent behind it, and not all behaviors are intentionally motivated. Things like tremors, choreiform movements, or like alien limb movements lack intentional motivation. And not all motivated behaviors are impulsive or compulsive. Most are just things we meant to do for what we would consider, normal reasons. So when trying to really conceptualize my patients, I realized that at some point I don't really understand the difference between an impulsive motive and a compulsive motive. The DSM is there to kind of help, but it does have chapters that use these words in the titles. There's the obsessive compulsive and related disorders chapter, and then there's the disruptive impulse control and conduct disorders chapter. Obsessive compulsive and related disorders, a lot of them had previously been defined as either anxiety disorders or had been included in the chapter with other impulse control disorders before DSM-5. Psychiatrists might also talk about, say, like substance use as being impulsive, or at times they talk about it as being a compulsive type of behavior. There are also disorders of like sexual behavior that are variously described as impulsive or compulsive. And personality disorders have criteria that include things like impulsive acts, or things that would be interpreted by their provider as being impulsive, or maybe even at times compulsive, especially things like borderline or antisocial personality disorders. And there is a personality disorder called obsessive compulsive personality disorder. So surely so many things, so many different kinds of things, are not really adequately or precisely differentiated by just two meager words. Let me discuss some of these diagnostic entities in a bit more detail. Disruptive impulse control and conduct disorder diagnoses share the common factor that the behavior that a person exhibits violates social norms, such as killing people's pets for fun, setting their neighbor's shed on fire for no apparent reason, or just stealing things like your neighbor's garden gnomes for no apparent reason, just because you just have to have them, or screaming at someone in public for no apparent reason. Maybe impulsive actions are actions that happen for no apparent reason. But unfortunately, this is not even close to universally the case. Impulsive acts are nearly always preceded by some kind of urge or maybe tension within the person who is committing the act that pushes them toward that act. I mean, interestingly, the DSM-4 and 5 diverge in how they describe the obsessive-compulsive disorder criteria by replacing the word impulses with the word urges, among other things. For example, the definition of an obsession in DSM-4 is recurrent and persistent thoughts, impulses, or images that are experienced, etc. While the definition of an obsession in DSM-5 is recurrent and persistent thoughts, urges, or images that are experienced, etc. So this kind of find and replace just continues through the criteria. Wherever impulse was used in the DSM-4 for OCD, urge is stuck in its place. It seems like an attempt to kind of segregate the two terms, compulsive and impulsive, by not using one to define the other. Another seemingly purposeful grammatical choice is the use of the term tension to describe the state of an individual driven to set fires or steal something for no apparent value. So this would be like your pyromaniacs and your kleptomaniacs. So in the criteria in the DSM-5, the person experiences something prior to doing the act. And in the case of impulse control disorders, it's described as tension. In the case of obsessive compulsive disorders, the thing that precedes the act is described as an urge. So I ask again, what is the difference between impulsive and compulsive behaviors? Is it that one results from tension and the other results from urges? I mean, tensions and urges seem a lot like the same thing to me. If we define tension as maybe a vague, ephemeral motive and an urge as a specific, persistent motive, then maybe the DSM actually makes sense. But this sounds like special pleading to me. And it's not clear in the text that that's what it really means. So one way I try to think about this is that maybe impulses are behaviors that happen before much thought or enough thought happens, while compulsions are behaviors that result from pesky thoughts, like thoughts that someone just can't ignore. So impulses are, say, fast and precocious. Compulsions are tedious and inflexible. As soon as we, that means humans, either imagine something or we see something, our brain automatically starts planning out an action. So like if you're watching someone dancing, your brain is actually planning out those movements in your head, kind of as a way to get ready to execute them, or maybe to understand them. Or if you imagine punching someone in the face, your brain is already preparing for that movement, even if you don't really plan to do it. If you see something you want, your brain is pre-planning a path to that thing. I mean, controlling whether or not we do or do not do the thing that our brain is mapping out is a critical skill. The reason that I'm making such a fuss about these words is because to be able to gain a deep understanding of our behaviors and develop novel treatments or use the appropriate current treatments, we need to know the neural mechanisms that are at play. Vague language doesn't do much to help us to understand, even where to start. Does using the term impulsive for addiction and sexual promiscuity and pyromania and antisocial behaviors really describe the same kind of thing? I'm not sure. I suspect the term impulsive refers to very different kinds of things. It can refer to having some kind of bias toward action, like the brain is ready to act And it really only takes a small impetus to make it so. We are what you might call disinhibited. It could also refer to a problem with our ability to plan things out, like to take small steps toward a goal, like to decide what is the next best thing to do instead of what is the easiest thing to do. It could also describe being like overconfident and just acting too quickly, deciding what to do before we actually have enough information to make a good decision. I stumbled across a paper in Neuropsychopharmacology from 2010 titled Probing Compulsive and Impulsive Behaviors from Animal Models to Endophenotypes, a Narrative Review. You can look at the bottom of my show transcript at didactic.buzzsprout.com for links to articles and things that I read while I was creating this podcast. But this paper from 2010 in Neuropsychopharmacology identified those 3 types of impulsiveness that I just mentioned and also correlated them with different brain networks. The kind of impulsiveness that is precocious, that happens before its time, that is too ready to act, too easily induced into action, is thought to be the result of a malfunction within the right inferior frontal cortex and the subcortical connections that it has. So the premotor region has planned out an action, let's say, and it's rearing to go, but it's kind of being held back by something inhibiting inappropriate or actions that happen too soon. That hold signal involves the right inferior frontal gyrus. Psychological testing in the form of like a stop signal reaction time may be able to demonstrate like the kind of impulsivity that would result from damage or hypofunction of this region. So this type of impulsivity was proposed to be modulated in this paper mostly by the noradrenergic system, by noradrenaline or norepinephrine, and to be relatively insensitive to serotonin. So SSRIs, for example, would not treat this kind of impulsivity. Maybe SNRIs or just the NRIs or the dopamine and norepinephrine uptake inhibitors, or maybe stimulants would be helpful for this kind of impulsivity. The second kind of impulsivity is related to what the author describes as delaying gratification instead of choosing immediate small rewards that result in problems or failure of your long-term goals. This kind of impulsivity it's kind of like missing the forest for the trees, getting distracted from the goal. The belief is that this kind of impulsivity is actually mediated through the orbitofrontal cortex and its connections to other cortical regions, such as the ventral medial prefrontal cortex and the dorsal anterior cingulate gyrus, and is proposed to be heavily influenced by serotonergic neurons. So that right inferior frontal cortex was thought to be influenced more by like noradrenergic neurons, and this orbitofrontal region and its connections more heavily influenced by serotonergic neurons. So someone who is making poor decisions and not following through and planning out might be helpful to modulate the serotonergic system. The third kind of impulsivity they describe is kind of like, my words are like it's overconfident in decision making despite not having adequate information. It's not like making a decision despite long-term consequences, but actually thinking like that you have enough and that you're right, and you do this with very little information. So this kind of impulsivity might be characteristic of people with like conduct disorder or antisocial personality disorder. And it's also proposed to be related to dysfunction in the orbitofrontal cortex and its connections, like the medial cortex. So parts of the orbitofrontal cortex, if functioning correctly, should act kind of like an accountant or an economist in our brain. So if calculating correctly, it should know whether or not all the variables that we need to be accounted for are accounted for, and what grossly it expects the outcome to be if we choose one course of action over another. If this area is not functioning correctly, then it may allow a decision that is really not well thought through or that lacks available information. And this decision could be influenced by like sort of massive overconfidence in our ability to take the limited amount of information we have and make a decision from it. If you remember some of my past episodes, you may say, but Dr. O'Leary, you mentioned before that compulsive behaviors are related to malfunction of the orbitofrontal cortex. So what gives? Impulsive or compulsive? Honestly, I'm not sure what gives. We don't have a very good understanding of the difference between the motives for impulsive and compulsive behaviors neurologically, and we also don't understand the fine details of the neuroscience behind them. We have some clues that someone who acts before considering any outcome at all, like just immediately, may respond better to like noradrenergic agents, and those are the people with the proposed dysfunction of the right inferior frontal gyrus. And alternatively, there are those who are overconfident or who can't incorporate new information, and they may respond better to serotonergic agents. I haven't even mentioned ADHD, which has been defined as an impulse control disorder before now being put in a neurodevelopmental disorder, but a lot of people still call it an impulse control disorder. Impulse control in ADHD is evidenced by hyperactivity, being excessively loud, talking out of turn, annoying others, etc. It's also frequently an attention control disorder where a person is under-responding to environmental cues at times or just easily distracted by unimportant environmental information. A paper in Neuroimaging in 2010 called The Role of the Right Frontal Gyrus, Inhibition and Attention Control demonstrated that the right inferior frontal gyrus is very active when a person needs to respond to cues in the external environment, regardless of whether or not it needs to inhibit action. So it's involved probably in inhibiting actions, but also in a lot of attention control processes. So it makes sense then that stimulants or noradrenergic reuptake inhibitors like atomoxetine treat ADHD because these agents increase available norepinephrine, which may help the right frontal gyrus to both control attention and to prevent pre-planned but not needed or inappropriate actions from actually happening. So I've spent the last few minutes explaining that there are different ways to conceptualize impulsive actions that result from either an excessively low energy of activation, like you need very little impetus to act, or a paucity of information, either because immediate rewards become too distracting or too attractive, or because we are overconfident. Given that there are these, and likely other things people mean when they're saying impulsive, merely saying that a patient is impulsive does not really communicate anything specific. Instead of simply saying impulsive, which could mean many things, a behavior or tendency could just be better described. For example, I could say, makes poor decisions due to not considering all available information. Or I could say, patient acts before thinking about the consequences and often regrets the choice. I mentioned earlier that compulsiveness can be thought to differ from impulsiveness by being more a problem with too much thought or too much of one thought instead of not enough consideration of your thoughts. By that I mean that the motive force or the intention of the action is obsessive. The same information is considered again and again and again and again and again despite providing no new insight or no new information. It's not a pre-potentiation problem due to a lack of inhibition of a pre-planned motor response. It's also not specifically a problem of considering enough information, except that when obsessions are delusional in nature, they prevent the person from ever considering any alternative. Instead, compulsivity is a problem with cognitive flexibility. People with OCD have difficulty with reversal learning, which is basically adapting their future behaviors to new information when it's provided. I mean, despite looking at a locked door for the 12th time, they can't learn that the door is locked. Despite their mom never dying when they step on a crack, they just can't not avoid cracks. How did you like that double negative? So people with OCD also have problems with attention because they can't really switch their attention away from an obsession until the compulsion is sufficiently complete. This means that the neurocircuits for impulsive and compulsive behaviors likely overlap a lot. An article from 2015 in the Harvard Review of Psychiatry called Comorbidity Between Attention Deficit Hyperactivity Disorder and Obsessive Compulsive Disorder Across the Lifespan reported very high variability or inconsistency in the rates of reported comorbid ADHD and OCD symptoms and studies. And it concluded that many of these associations are highly exaggerated. And they thought this is due to kind of how we diagnose things. If we're not distinguishing between impulsivity and compulsivity in our diagnostic process, or even kind of the different kinds of impulsivity itself, then we may be misled by the result. So a patient is performing poorly in school or work, appears to be doing or saying inappropriate things, and has a hard time concentrating. That could be ADHD or OCD pretty easily. But how they got to that point could be very different. So let me quote from this paper their characterization of one way to look at impulsivity versus compulsivity. Quote, when addressing the concept of comorbidity between ADHD and OCD, it is useful to consider the notion of an impulsive-compulsive continuum, as suggested by Hollander. According to this hypothetical scheme, the compulsive end of this continuum, which is associated with OCD, is characterized by harm-avoidant and risk-averse behaviors. Conversely, the impulsive end of the continuum is characterized by behavioral impulsivity, i.e., behaviors lacking forethought, and risk-taking. According to Hollander, the concept of polarity between the two constructs is further supported by neurobiological and neurochemical differences. For example, on the neurotransmitter level, impulsivity is mediated by dopamine, whereas compulsivity is mediated by serotonin. In sum, ADHD and OCD appear to be remarkably different in terms of their phenomenology. Unquote. I mentioned before some of the cortical regions implicated in ADHD and OCD, and that there is overlap. I haven't yet highlighted that ADHD is consistently characterized by hypofunction of the right inferior frontal gyrus and other frontal regions, while OCD is associated with hyperfunction of the orbitofrontal cortex. So this makes Hollander's continuum scheme seem appealing. However, to characterize OCD as harm avoidant, I think only applies to some cases, and probably most cases, but it depends on the obsession. Other OCD-related disorders that we've put in that chapter now, such as trichotillomania or skin-picking disorder, are associated with self-harm, but it also may be the self-harm that is meant to prevent some other kind of harm from happening. Also, the authors of the paper point to dopamine as a driver of impulsivity. Dopamine in our reward centers drives us toward novelty and toward reward seeking. We know that dopamine agonists, like those used in Parkinson's disease, can result in patients and animals engaging in behaviors that they may have never done before. It appear to be very impulsive, like gambling or being very sexually promiscuous. We call these impulsive behaviors, though they're also and frequently excessively or rigidly goal-driven. So I wonder what that means. Dopamine agonists can also result in repetitive behaviors that resemble compulsions, in addition to the impulsive behaviors. So patients with OCD who don't respond fully to serotonergic agents may respond to the addition of a dopamine blocker, an antipsychotic. But the response rates are not super high. Some drugs can result in a relative flood of dopamine in the nucleus accumbens. Is dopamine-driven impulsivity the same as impulsivity described with ADHD that is treated most effectively with dopaminergic and noradrenergic agents? What I mean here is that I've often read that the mechanism of action of stimulants for ADHD is blocking dopamine reuptake or metabolism without any mention of norepinephrine. However, this simplistic view gives dopamine too much of the credit. It may be standing on the shoulders of norepinephrine in order to do its job. You need both, or especially norepinephrine. I think to conceptualize impulsivity and compulsivity as a continuum is tempting. And if you enforce very specific definitions of the two terms, this could be accurate, but it will miss much of the reality. As a construct, it's not very complete. I mean, it relies on an oversimplified neurobiological model of brain function, OCD being associated with too much activity in the frontal striatal circuits and relative serotonin deficiency and dopamine excess, and ADHD with too little activity in the frontal striatal circuit and relative dopamine deficiency. Embracing this model, you would need to downplay the role of norepinephrine, and you would also need a lot more words for all the other things we currently describe as impulsive or compulsive that don't fit on that continuum. While struggling with trying to define and differentiate compulsive and impulsive motives, I've discovered that they're likely not just two different things, but even within themselves, they're different things. However, they are also highly related things. They are, you could say, polyphyletic in that you can draw a circle around things, but they don't have a single common antecedent or explanation, but they still share common pathways. Describing a behavior instead of merely reporting it as compulsive or impulsive will probably help prevent miscommunication in the future and can help really inform treatment. I mean, looking for patterns in behaviors and asking what prompted the behavior is very important. We have some insight in how the brain decides to do what we do. It appears that there's some tonic inhibition that involves, probably among other things, but especially the right inferior frontal gyrus. Loss of this inhibition due to hypoactivity of this region results in behaviors that are almost automatic, like blurting out answers or making annoying sounds or failing to adjust your volume or failing to identify or respond to important other details in the environment besides what you're engaged in the moment. Behaviors that require more decision-making often involve broader regions of the prefrontal cortex and appear to be managed to some degree by parts of the orbital frontal cortex. These can range by, say, being satisfied with only a little bit of the relevant information that is needed to be able to make the decision, or being completely dissatisfied that the result that you just quadruple checked is real or durable. If listening to this podcast has accomplished anything, I hope it is at least that the next time you speak the words impulsive or compulsive, you also have a voice in your head asking, well, what actually do I mean by that? Thank you for listening. I am Dr. O, and this has been an episode of Sidactic Residency Edition.